The last major class of antidepressants, the MAOIs, or MAOIs as I call them, is the least selective of all. They're used as a last-line drug for major depressive disorder and the anxiety spectrum disorders because of the significant side effect and drug-drug interaction profiles that they're notorious for. That being said, they are effective drugs and are especially effective in atypical depression. Now, these drugs are the most irritating set of names because they sound nothing alike. At least with the TCAs, you could recognize the pattern. The drug names are tranylcypromine, phenelzine, isocarboxazid, and selegiline, which you can remember with the excellent mnemonic, Mao takes pride in Shanghai. Selegiline is kind of an interesting drug because it's also used in Parkinson's disease and is a MAO-B specific inhibitor. This becomes a little bit more important because of all the dietary interactions that the MAOIs are known for. Those are actually caused by MAO-A inhibition. So the MAOIs have their own arsenal of side effects that overlap a lot with the TCAs, but what you'll actually be tested on is the fact that MAOIs interact with a ton of medications and foods in potentially lethal ways. The first potentially lethal interaction is called the hypertensive or tyramine crisis, which is what happens when patients on MAOIs eat aged cheese, wine, Marmite, or any other tyramine-rich food. Well, how can your food kill you? As it turns out, one of the dietary amines, tyramine, is normally metabolized by MAOA before it's absorbed. But if MAOA is taken out of the picture, tyramine is directly absorbed into the bloodstream. And that's bad news bears because tyramine itself has some pretty significant monoamine activity, causing things like hypertensive emergencies and CNS stimulation. The other major interaction you need to know about is serotonin syndrome, which occurs as a result of a lot of the serotonergic drugs, though MAOIs are the most commonly associated with it. So, the first thing you need to know is that serotonin syndrome presents a lot like neuroleptic malignant syndrome, and while reading a lot of these vignettes, it can get pretty hard to tell the difference. Remember the mnemonic for NMS? It's fever, and a lot of these apply to serotonin syndrome as well. Serotonin syndrome is characterized by fever, encephalopathy, by which we mean altered mental status, and unstable vitals, in a potentially lethal way. Towards the end of the mnemonic is where we start to see some of the differences. CPK elevations are sometimes present, but it isn't as prevalent as it is in neuroleptic malignant syndrome. And muscle rigidity? That's actually the biggest distinction of all. Serotonin syndrome actually doesn't see any muscle rigidity. It's actually more likely to show increased movement in the form of myoclonic twitches and hyperreflexia. There's another few serotonin-specific syndromes, but they may or may not be pleasant. It's kind of like what you see in carcinoid syndrome. And another important way to distinguish between the two is that serotonin syndrome develops pretty much immediately after the meds are given, whereas NMS develops within hours or even days of when the medication's first administered. But this is all icing on the cake afterwards. Like I told you in the antipsychotics section, the first thing you have to look for is to pay attention to what drug the patient took before the episode started. That will really be the money question you have to ask. Now, the treatment for serotonin syndrome is called cyproheptadine, as compared to either dantrolene or bromocriptine for NMS. So, while a single heavy dose of an MAOI or another serotonergic drug could in theory provide the serotonin needed for frank serotonin syndrome, the syndrome is usually caused by drug combinations. The antidepressants we discussed so far are all capable of causing serotonin syndrome, as is St. John's wort, an herbal remedy that actually has almost as many interactions as the MAOIs. A lot of other medications can contribute, but the most important ones you need to know that aren't antidepressants are the opioid meperidine and the antitussive dextromethorphan. So that covers the main classes of antidepressant. The last three are the atypicals, and because for a lot of them the mechanism isn't entirely clear, it's almost never going to be tested. What dictates whether we use them or not depends a lot on their side effects, and for that, I'm going to compare them to the SSRIs, which are our gold standard drug. So the drugs we're going to compare and contrast are bupropion, which is not the same as buspirone, mirtazapine, and trazodone. So the thing that they all have in common is that they're all used to treat major depressive disorder, and you'd think that'd be obvious, but trazodone is actually a lousy antidepressant. It only has antidepressant effects at really high doses, and even then they're not very good ones. None of these are indicated for use in the anxiety spectrum disorders, but bupropion's additionally indicated for use as a smoking aid, and trazodone's so sedating that it's mainly just used for insomnia these days. But like I said, the really high yield stuff comes from the side effect profile, because that's what determines who you can use these medications on and who you can't. Bupropion and mirtazapine are kind of like yin and yang when it comes to side effects. While bupropion almost acts like a stimulant, mirtazapine promotes both drowsiness and increased appetite. So which one's better? Well, it all depends on how that particular patient experiences depression. Bupropion's benefit, which I alluded to earlier, is that it causes neither sexual dysfunction nor drowsiness, so it may be a great choice in the patients that really don't like either of those effects. Mirtazapine, on the other hand, works really well for a lot of your patients with the classic melancholic depression, where they don't sleep and they don't eat. Other than that, bupropion's main side effect is that it lowers the seizure threshold, making it problematic for patients with seizure disorders, and especially for patients who vomit on a regular basis. So watch out for this in your anorexics and your bulimics. Mirtazapine causes dry mouth, which is not usually a huge deal, it's just kind of annoying. And trazodone, which we haven't really talked about, is so sedating that it's mostly just used as a sleep aid. It also has another cluster of side effects, including orthostatic hypotension, nausea, and priapism. Now, priapism is the one that everybody remembers. This is actually the least common of all of them, but it's hilarious because you can remember the drug as trazobone. Just watch, next year the psych clerkship directors are going to try desperately to re-educate you, but it's not going to work because, y'all have dirty minds. That concludes this section on antidepressants, and therefore the psych pharmacology section. Let's wrap this up with one final flash quiz. This is my final question to you guys, so savor the moment. Question is, which class of antidepressants has the lowest therapeutic index? Pause if you need to think about it. And the answer is the tricyclic antidepressants. Remember, the therapeutic index is a measure of how many times over a normal dose you have to go in order to see an acute drug toxicity. For the tricyclics, you only have to take 10 times your daily dose in order to get a lethal overdose. I mean, that's worse than most benzos. Remember, while the TCAs can have a number of side effects, the effects of acute toxicity can be remembered as the 3 C's: convulsions, coma, and cardiotoxicity. And that wraps it up for pharmacology. By now, you should feel like a psychiatry machine, armed with all the knowledge you need to ace this test. But as you know, you also got to be able to apply that knowledge in a test-taking scenario. We're going to finish up with a couple board-style questions. I deliberately picked some of the harder ones, so don't get down on yourself if you don't get them right. Remember, this is a process. So when you see the questions, I'm going to give you some time to read and solve them. Then afterwards, I'm not only going to go over what the right answer is, I'm also going to show you how to think about these test questions as you do them. Everyone got that? All right, let's go. A 22-year-old man with schizophrenia is being treated as an inpatient with a first-generation antipsychotic medication. Several hours after his initial dose, he develops involuntary muscle spasms, particularly in his facial muscles. To which class of drugs does the indicated treatment for this patient's adverse effects belong? Is it A, beta blockers, B, anticholinergic agents, C, anti-epileptic drugs, D, atypical antipsychotic agents, E, dopamine agonists, or F, mood stabilizers? So, this really is a multi-step question. One of the best things you can do in this case is to skip straight to the bottom to figure out what exactly it is you're supposed to be answering. In this case, the question's asking you which class of drugs you need to use to treat the patient's side effects that he's experiencing right now. Keep in mind, this is worded pretty strangely here, which is unfortunately not unheard of on the actual step 1. So, when you read the question, it becomes clear that this guy got a first-generation antipsychotic and pretty soon afterwards developed muscle spasms. Remember, because with the antipsychotics, time course can be important, it's important to realize that it's several hours after his first dose when he's still in the hospital. Sound like any side effects you know? It's acute dystonia, a side effect that's known for happening pretty soon after you administer the medication. Remember, acute dystonia occurs as a result of decreased nigrostriatal dopamine, and in that pathway, ACH and dopamine essentially counteract each other. So if the problem is decreased dopamine, you correct the movement disorder by also decreasing the acetylcholine in the basal ganglia. So let's go over some of the incorrect answer choices and trap answers. If the patient is schizophrenia, you really want to avoid giving him a dopamine agonist. Now, some of you might have thought this is a logical choice because the problem was with dopamine blockade, so you might want to increase the dopamine. You don't actually do this for the extrapyramidal symptoms, because remember, they're on antidopaminergics for a reason. They're going to go into full-blown psychosis if you give them a dopamine agonist. You are, however, permitted to use dopamine agonists in the life-threatening syndrome, neuroleptic malignant syndrome. But for the extrapyramidal symptoms, you definitely don't want to use these. Now, you may have confused the patient's symptoms for a partial seizure and opted to give him antiepileptics. That's kind of understandable because they can look pretty similar. However, while there are a ton of side effects associated with the antipsychotics, seizures aren't really a major risk for any of them besides clozapine, which is a second-generation antipsychotic. So antiepileptic drug is not the right answer. And while maybe you should have tried a second-generation or an atypical antipsychotic initially to avoid the dystonia, saying shoulda, coulda, woulda and giving him an atypical now isn't going to treat the dystonia that he already has. A couple of the others, beta blockers, they're used for tremors, not muscle spasms. And honestly, I have no idea why mood stabilizers are on this list. That doesn't make any sense to me. The next question is sort of a crossover question that requires you to bridge the gap between psychiatry and medicine. Let's check it out and see how you do with this one. A 32-year-old woman with a history of bipolar disorder is brought in by her husband to the emergency department after overdosing on her psychiatric medication. She's been feeling nauseous for the past few hours with several episodes of vomiting. Despite being thirsty, she's been unable to tolerate any liquids or solids due to her vomiting. On physical exam, she appears lethargic with dry mucous membranes. Neurologic examination reveals bilateral coarse hand tremors, dysarthric speech, and ataxia. What laboratory abnormalities might this patient have as a direct result of her patient's toxicity? And the answer choices are all values related to serum sodium, serum osmolality, urine osmolality, and urine-specific gravity. And that's time. Let's see what you made of this one. So, if you skip to the bottom, you'll see that this is another drug toxicity question. There's a lot of these on this test. But the nice thing about scanning the last line and all the answer choices is that you don't really need to read very far to know what sort of question's being asked. This patient is bipolar disorder, which could mean one of the anticonvulsants or an antipsychotic. But if you skim the answer choices, you'll see that they're really all about osmolality and sodium balance. Basically, this is a diabetes insipidus question, and that's a side effect of lithium. So what the question's really asking is, what lab abnormalities does a person with diabetes insipidus present with? Literally, after that, the vast majority of this passage is completely irrelevant. Hopefully this convinces some of you that it's worthwhile to read ahead. So, if you take a look at the answer choices and you find yourself face to face with one of the most annoying questions in endocrinology, the lab values grid. The reason it's even more annoying is that you've got actual lab values instead of increase-decrease arrows. So let's switch this up to Argent Vision, where red means too high and blue means too low. There we go, that's better. So, with these box questions, the way to play is by aggressively eliminating answer choices starting with the lab value you're most confident of, and resisting the urge to recheck every single answer choice, because that's a really good way to waste time and second-guess yourself. So, which lab value are you most confident of in diabetes insipidus? Surprisingly, even though the name means bland pee, dilute urine isn't really the first thing you should look for. Remember, urine can actually have a huge range of concentrations depending on how dehydrated you are, and that's why I didn't bother flagging any of the urine values. Diabetes insipidus, however, is characterized by continuing to produce huge amounts of dilute pee no matter how dehydrated you get or how concentrated your serum becomes. So the first thing you look for is a high sodium concentration, which eliminates A and B, and a high serum osmolality, which eliminates answer choice D. Not bad, you're already down to 2. Now between C and E, C has a relatively higher urine concentration than E does. Between C and E, C actually represents the normal response to concentrated serum and dehydration. If your serum's concentrated, the kidneys try to conserve water and sodium and produce concentrated P. But we're not talking about a normal patient here. This patient has lithium toxicity, so we expect her to have diabetes insipidus. And the classic picture of DI is to continue to generate dilute urine even when you're all dried up. And that's answer choice E. And that's it for psychiatry. Hopefully you like these videos. I know psych isn't everyone's strongest subject, but hopefully I could make it a little bit more accessible and interesting than you originally thought. If you liked my psych videos, let me know by giving me a thumbs up down below. And leave some comments if you have the time so we can improve this for next year. Thanks so much for watching, everybody. Arjun Iyer, signing out.